And welcome to this evening's webinar on interstitial pulmonary fibrosis. I might not be the person you expected to see, but my name is Helen Malherbe and I head up research and epidemiology at Rare Diseases South Africa. And we've had to do a quick change at the last minute because unfortunately we're having some connectivity issues both with Kelly and NOMSA due to load shedding. So they are both online and they will both be participating as and when they can. But equally, they might drop off as well and come back. This is South Africa. So welcome everybody. And we've got quite a nice panel here and some to really trigger some discussion and some engagement tonight on this condition. And I'm just gonna, just before I introduce all of the speakers and so on, I just want to emphasize that this is a safe place. And it's just an opportunity just to share what's going on with you if you are living with IPF, asking all of those questions that you've ever wanted to ask. Now's the chance, and just sharing things. I think it's just it's a sharing, caring space. And I might not have, you know, the bubbly personality of NOMSA and the big smile, but I'm bringing this from a different angle from my perspective, but we just want to facilitate this discussion and just enable you to put everything, the issues out there, and just so we can connect and just really focus on the personal experience tonight of living with IPF. So if you have questions, you can either drop them in the chat or preferably you could put them in the Q&A. And they may be answered live or they'll be brought to my attention so we can either pose them to Dr. Viviers or Stephanie, who's joining us tonight. Please also just drop into the chat, say hi, say where you're coming from, where you're sitting tonight, whether it's dark or if you have power, your names, and yeah, and just tell us a little bit about yourselves. Also, feel free to, we can always unmute you or you can unmute and then we can just let you talk and pose your question directly. So I think let's get on with it. And I'd like to hand over now to our first speaker, who's Dr. Viviers. He is a pulmonologist with ample experience with anything to do with pulmonology or pulmonology related. He has, having been in the pulmonary side of things, he's worked with many diseases, and one of them is obviously IPF. And Dr. Viviers is now going to share some insight and a little bit of education about IPF, ranging from symptoms to treatment, and just to ensuring the quality of life for patients that are affected by IPF and are impacted by this condition. So great to have you on board tonight, Dr. Viviers. Thank you for joining us, and it's very nice to meet you. Over to you.
Good evening, Helen. Thank you very much for the kind introduction. And I endeavored to answer as many questions as I can, although I must admit that we don't have all these questions answerable. We are in a struggle with this condition. There are a lot of unknowns, and certainly if there are patients, you know, looking at this, we're all in the same boat together, and it's not a very nice boat. It's a rocky boat. It's a bad place to be for patients that are confronted with this diagnosis. So I would just like firstly to point out a few terms, because if you go and see a doctor and you get a scan or an x-ray performed and you read the report and you read the word fibrosis, and this is what we see in clinical practice, you know, most patients, when they see that word, they sort of don't understand what it means. They go over to Dr. Google, they Google fibrosis, and they see, oh goodness me, I've got 2 years to live. So firstly, just to point out, when we talk about fibrosis, what do we actually mean? The word fibrosis just refers to scarring, and this scarring can occur anywhere in the body. If I go for surgery, I will always have a scar, depending on how good job the surgeon did. I might have a small scar or a big scar, but scarring is the natural, normal healing process. It's supposed to happen after injury. But when we talk about IPF, which is idiopathic pulmonary fibrosis, we are looking at a very rare disease where the lung on its own accord starts making scar tissue for reasons unknown to us. We've got a certain idea of where it might come from. The world is trying to see if we can find an etiology, but we're not sure. We know this disease tends to happen in the 5th and 6th decades of life, usually in men, usually in old ex-smokers. So IPF is really a rare condition. We're talking 20 to 30 out of 100,000 people. So it's not a disease that affects many people. Although when you look at a scan picture or an X-ray result, you might read fibrosis quite often, but it does not imply that there is IPF. So IPF needs to be diagnosed by a specialist after performing a CT or a CAT scan. So the diagnosis needs to be certain, and just using the word fibrosis in a report does not mean a patient has lung fibrosis. So most of the time fibrosis might occur, for example, after COVID. And that's why I'm mentioning this. Many patients suffered from severe COVID pneumonia, ended up going for scans, and the scans looked horrible. And then patients will see, there's lung fibrosis. And now imagine surviving severe COVID just to find that you now have a lung fibrosis and you're going to die in 2 years. And that's not the case. So the first thing is for patients, to question these results, not to go to Google, and make sure they know what the report is referring to. So if you get back to IPF, it is a devastating condition. It is rare, but in those patients who do get it, it's a devastating diagnosis. And I think when we first mention this diagnosis to a patient, we as clinicians know what it is all about. We know the prognosis, but patients often don't know, and their family members don't know the impact of this diagnosis. I had this patient once whom I shared the diagnosis with. We made the diagnosis of IPF. We discussed the diagnosis, and at the end of the discussion, the patient said, well, luckily, it's not lung cancer. This is the sad part of it. Lung cancer has, in most instances, a better prognosis than IPF. True IPF has a 50% mortality of 2 to 3 years. In other words, if I diagnose IPF today, within 2 to 3 years, half of those patients have succumbed to this disease. And I think this really emphasizes the need we have for effective therapy. So I think the main community impact of this condition is, number one, we need to diagnose it earlier. We cannot diagnose this condition 6 months before a patient is dead. So we need to create awareness, not just at specialist level, specialists also, but at general practitioner level, to start thinking about the disease. This is a very rare disease. It's not a disease a GP is going to diagnose every week or every month. A GP might see IPF in his or her practice once every 2 or 3 years. But it is a disease that if you think about it, you're going to diagnose it very early. There are a few signs that you can look for that can help you. So once the diagnosis is thought about, once you think of the diagnosis, it becomes a bit easier. Then you just need to be able to fund a CT scan. And a CT scan is really what you need to diagnose. We don't do lung biopsies as we used to. We've got very good guidelines to aid us. Modern CT or CAT scan technology have really come a far way in the last few decades. So it's very rare that we need to do open lung biopsies like we used to. So with a good quality scan, you can make the diagnosis 95% of the time. And once you have the diagnosis, you can open up avenues towards treatment. And I think that's one of the exciting parts of being where we are now, Helen, is the fact that we have opportunities to treat patients. Over the last few years, it's been a bit of a difficult ride. We had access to a drug imported from overseas that were quite affordable. That drug has since been removed. We can no longer import it, but we have 2 registered agents in South Africa. Quite costly, but again, if you look at how effective they are and you look at how rare this disease is, I don't think it should be a funding problem. I certainly, in my practice, I cannot lie, but I would say about 40 to 50 patients in my practice are already on one of the new agents, and I've got about another 70 waiting in limbo for medical aids to approve. So I do have experience with these drugs, and I've had patients on these drugs for the last 6 or 7 years, and they do impact very well, and they can convert that death sentence to hope. We are seeing patients surviving 5, 6, 7 years, or surviving up to the point of maybe getting a lung transplant. And that brings me to the next point. IPF is one disease entity. As I say, the I stands for idiopathic, which means we don't know. Idiopathic is a nice term doctors use if we don't know. So we tend to use idiopathic quite a lot. It sounds good, but it means we've got no clue. So with IPF, that is a disease where we don't know where it's coming from. But then we've got a separate group of interstitial fibrotic diseases where there's also scarring, but this is associated with another disease. So you get the same sort of picture on the scan. There's also the scarring and the fibrosis, but it's linked to something else. So they would come in, and I think you know foreign to this at the Rare Diseases Organization is lupus, for example, rheumatoid arthritis, systemic sclerosis, what we call scleroderma. So those conditions all predispose patients to develop fibrosis as well. So lupus can affect the lung in very much the same way as IPF. And now for these patients who have not really IPF, but the fibrosis linked to one of these conditions, there's also treatment available. And generally the prognosis here is a bit better, but it is more frequent. So your IPF patients, as I said, about 20 to 30 out of 100,000. But if you look at lupus patients, scleroderma, rheumatoid arthritis, and sarcoidosis, those patients, if you add them all together, it's about 150 out of 100,000. So they are quite more common. They are still serious, but they're less serious than IPF, and they certainly have a better prognosis long term. And now, since February this year, we now have a registered agent in South Africa specifically for these patients as well. So we call them PF-ILD. So these are the progressive fibrotic interstitial lung diseases. So you've got the IPF as an entity on its own, worse prognosis, quite rare. We've got treatment for that, and now we've got can I say almost another twin, a fibrotic disease as well, but linked to a systemic disorder. Prognosis slightly better, and we do have medication available for that as well. Finally, I think one of the big issues with treatment and diagnosis is I work, unfortunately, only in a private sector. Access for us to get a patient to a scan is very, very easy. It's relatively affordable. Our biggest need, obviously, is always going to be in the state sector, where the majority of patients are lying. I think an IPF diagnosis in the government sector is even more difficult to get. So I think many of our IPF patients at the moment are undiagnosed at government clinics, being missed, and we diagnose those patients extremely late. And I'm not aware that at government level we yet have these agents available. So it will be, quite interesting to see what happens when our universities and SATS, South African Thoracic Society, can sit down with government policymakers and say, well, when can we have these drugs available? We do have expensive drugs available in the government service, so expense and cost shouldn't be an issue. As I say, these are not common diseases, but we should be, finding ways of opening doors, and we have been doing that. I won't mention any names now. I don't think I'm allowed, but there are 2 or 3 companies and pharmaceutical companies in this country that really, over the last year, have done massive amounts of work to open up these drugs to patients, to make them accessible. And we are constantly trying to make this happen between funders, the patient, and the pharmaceutical industry to get patients on these medications. And obviously, the earlier you can treat patients, the better outcome is going to be. Not treating this disease is devastating. You're asking about the community impact. As I say, the prognosis is worse than for cancer. Very often, these are patients that are still economically active. They work. They've got no comorbidities. These are not patients sitting in wheelchairs and waiting to die. These are very often active members of society. And once they get these diagnoses, within a few years, the wind is taken out of their sails. So I think that's, in a nutshell, what we're looking at. Firstly, getting the diagnosis right. The diagnosis has to be right early on, not waiting too late. And then with your private or public, trying to open avenues to get treatment as quickly as you can, and then adequate follow-up of our patients after that. So I think in a nutshell, that's where I would like to start. And please, Helen, if there are any questions that we can answer, I'm glad to answer what I can.
Thanks. That was such a good overview. I learned so much already. Thanks. I don't know about other people. And I'm thinking, I guess that COVID has actually really pushed this onto, like top of the list in many respects, because it's become more of a priority. Is that the number that you gave of 20 to 30 per 100,000? Is that pre-COVID or post-COVID?
So those are pre-COVID, absolutely. They are pre-COVID and then non-South African numbers. Okay. I would venture to say it's probably going to be higher. We have a history of very high pneumoconioses in our country. We've got more noxious exposures for patients in the mining industry. So, dare I say, it might be slightly worse in our country, but I think those patients are diagnosed late. An interesting point on COVID, we don't yet know if COVID predisposes you to true IPF. At the time when you have COVID, even if you are extremely sick in ICU on a ventilator, those patients' scans look horrible if you look at them. They really look awful. And in my situation, there were 1 or 2 patients where I actually wanted to refer them for lung transplants. But what we are seeing, and I spoke to Professor Galigaro at UCT about this, and they have the same experience, that most patients with COVID, if you give them long enough, they do improve. So COVID is a once-off. It's a single hit. It's an injury to the lung, almost like an attack to the lung. But once it's gone, it's gone. So if you survive your 2-3 months in ICU, you go home. It might take 18 months. It might take 2 years. You might have long COVID. You might still have shortness of breath, but you don't progress to true IPF yet. We don't have data to support that. IPF is a constant injury to the lung. It's almost like a low-grade inflammation that continues throughout. It's a chronic disease. So it's slightly separate. So luckily, we don't see yet that patients, despite having fibrosis on the scan initially, we don't really see them developing true IPF yet. But the word is still out on that. We only have about 2 or 3 years worth of experience. We don't know where we're going to end up. But from personal experience and from colleagues with whom I had conversations, it does seem like most COVIDs, even the very severe ones, if you give them enough time, they do improve. So we hope we're not going to open up another batch of IPFs in those post-COVID patients as well.
Thank you. And there's a question come through on the chat asking about certain age groups. So like you did mention between, in the 5th and 6th, between the age of 50 and 60, mostly in men. Has that changed now with COVID, or is it still generally that age group? And are there any ideas around to what's causing it other than particularly COVID when it's, separated out?
Okay, so if you look at other causes of IPF, the moment we know the cause, it's actually no longer IPF. So if you know the cause, we don't call it IPF, we call it something else.
Okay.
COVID, lung disease, there is a mild, and this is a worldwide phenomenon, there is a slight male predominance in terms of severity and outcome. So the mortality is a bit against men in that case, but it's a very slight difference. I haven't seen a difference in gender gaps in terms of IPF yet. But what is interesting is that there is a subtype of IPF that patients can get when they're very young. So the so-called familial type. So we know there are certain genes that if you inherit those genes from your parents, you are more likely to develop IPF, even if you were a non-smoker, living in a clean environment, no chronic diseases, no chronic treatments. And these patients actually get IPF in their 20s and 30s with a very, very bad prognosis. So these patients tend to end up at lung transplant units in their 30s and 40s. So that's the so-called familial IPF subtype. It's even more rare. And I certainly, in my 9 years as a pulmonologist and 12 years as a physician, I probably have seen only 3. And those families usually get identified early on and patients get help quite early. So yes, that would be one type where the 5th, 6th decade predominance would not be the case. And yes, with COVID, I mean, last year, July, August, our average patient in our ICU, the mean age was about 52, with a range of 28 to 90. So we really saw much younger patients in our second wave of COVID. In our ICU, we saw 40, 50-year-old men and women battling it out there. So if COVID is going to predispose to long-term fibrosis, I think it will be in patients much younger than we would see in IPF.
And so just to lighten what I guess is a really, it's a really serious issue that we're facing. So it's more, it does affect men more. It's just not men. It's not men having bad man flu. You know how when a man has a cold, they have it a lot worse than a woman with the same cold.
Yeah.
I'm trying to chip in the same way that NOMSA would now. But yeah, so what else do you think we have to do to actually, I mean, you've said a lot of things that need to be done, but how do you think we can actually do that? I mean, it's going to require advocacy at a lot of levels, I guess.
I think the first thing that needs to be happening, and that is happening at the moment, is to create a registry. So at a professional level, we need to know how many of these patients are out there, what are their course of disease, and how do we open up treatment options for them? Do we have pulmonary rehabilitation? Do we treat them? That certainly is at the moment being pushed from the private sector, because in the private sector, we probably have in the country, I cannot give you a number, but probably about 500 plus patients already on antifibrotic treatments. So we can drive, that registry, and then hopefully this will spill over to the public sector as well. And I think eventually the pharmaceutical company currently providing treatment needs to sit down with government agencies. And I think the moment we have the treatment available at public level, then medical funders need to pay for it more because it's available in the public service. And then certainly patients who've never had any exposure to this drug will have it available. So it needs to be pushed, I think, top down. There's no point in diagnosing a disease, doing more scans, and saying, okay, well, we're diagnosing all these IPFs, wonderful. We were wondering where they were, now we're diagnosing them. But, oh, sorry, there's not much we can do about it. Because up to now, or let's say up to 5-6 years ago, the only option you had was oxygen therapy, which is quite non-expensive, but it's really a terminal treatment. Once you go on oxygen, you're looking at 1 year to 18 months before the end. So oxygen has been the only sort of treatment that we've had available. Looking at corticosteroids, steroids we know is harmful in IPF. It used to be the treatment that doctors gave because there was nothing else. And then we realized, based on data and research that came out later, that patients taking steroids, it's actually quite harmful for them. So you cannot treat this like you would treat any other lung disorder. You need specific antifibrotic treatments, and the treatments we have available actually go and stop that actual fibrosis from taking place. And the nice thing is it does so without affecting the immunity. So these are not immune depressing or immune modulating medication. They're not cortisone, they're not chemotherapies. So we're not treating them in the same way as we're treating lupus and all the other autoimmune diseases. So they're relatively safe. They do have side effects, of course, but they're relatively safe. So I think that should be our push, should be to open up treatment avenues for patients, have a registry where patients can be evaluated and centralized. We see the same with the rheumatologists. Eden, you probably know about SARA, South African Rheumatological Association. So they've done that already. They've got all the experience, which we don't. So the idea would be to have a SARA type system where the diagnosis can be centralized. It can be peer reviewed. So we can have a peer review committee that can say, well, absolutely, we agree. This is IPF and this patient can be treated. And this is a way to sort of, gatekeep the medication, because we don't want every patient with a little bit of fibrotic scarring from old TB. We don't want that patient on an antifibrotic. It's not going to do anything. So we need a true diagnosis. And that's difficult because you're sitting in a country with maybe 50 to 100 practicing pulmonologists and only a few more specialist physicians. So it's a difficult diagnosis to push down to GP level. I think at primary care level, you want those doctors to recognize the disease, think about it, and then refer for that scan.
And I guess that's going to require a lot of, education targeted at those GPs to do that as well.
Yeah.
So, and just thinking about the numbers you've already got in that registry with 500 patients, and it's just been established, and that's just the private sector. Those numbers are going to climb, hey? And We need
Yeah.
those numbers. We need to have the patients counted so that we can use that to inform the government to actually take action on this. So it's going to take a while, I guess, to find out how a bit more about the natural history or how the disease progresses, and so on. So it's going to take some time. And in the meantime, what about those patients, as has been raised as a question on the group chat, that those are in the state sector that are diagnosed late, or maybe not diagnosed at all? What happens to them? Are they just sent home with Panado, or
yes. Well, it's a sad state of affairs, but yes, that's exactly the point. If you get diagnosed in a system that cannot treat you, you might get a bit of pulmonary rehabilitation at best and oxygen therapy. And certainly when I was working in the government sector a few years ago, that was all we had. And I'm not aware of a government hospital that yet has access to the new antifibrotics. But I'm hoping it's going to happen quite soon, because that's always one way to get the medical funders to join the parties, to say, well, listen, you need to start looking at these therapies. It's available, it's effective, and it's now available in public sector. So it might initially be available only at 1 or 2 units or 3 units in the country. I mean, it will be at a quaternary level, but that's a good start, and I don't think it's ever going to be a drug that's going to be abused. We won't ever have thousands of patients being placed on these medications every month. It's always going to be a rare disease. But I think the more rare your disease, the more difficult it is to get the treatment that is actually not that cost ineffective. If you want to talk about an expensive disease, asthma is expensive, hypertension, diabetes, those are expensive because of the sheer volume of patients that have those conditions. But I certainly don't think that even in the public sector, this should be an obstacle towards treating patients. Cost shouldn't be the only reason. And then, of course, the more we use these medications, the cheaper they get. So the companies say, well, it's expensive to make. We only have 10 patients on it. It's going to be expensive. So they sort of wait for us to prescribe more so they can make it cheaper. On the other side, we are waiting for them to make it cheaper before we can prescribe it. So it's a bit of a chicken and egg.
Yeah.
But certainly the more patients we have on these drugs, we can then bargain for lower costs. And the two companies that have medications out in this country, both of them have dramatically reduced costs for the South African environment. I believe they can do even more
fantastic.
But it is quite cheap, much cheaper than it was 2-3 years ago when they were originally registered in the country. So we hope that can continue, and that every year there will be a decrease in cost.
And on that point, there's some questions coming in from some patients and family members. So Susanna is asking, her husband has just been diagnosed and his pulmonologist has told him that the antifibrotic medications are not available in South Africa. So how can they go about getting access to the medication for him?
No, they certainly are available. We've got a few patients on them. How can I make this easy for them? The pulmonologist just needs to find out, pick up the phone and phone. It's available. There are 2 companies, I can probably say the names, Boehringer Ingelheim and Roche. Both of them have products. The one drug is called nintedanib, and the trade name is Ipf. And the second one is pirfenidone, and the trade name there is Esbriet. Both are registered for IPF, but only Ipf is registered for those patients who have lupus, scleroderma, the IPF associated with systemic disease. So, and that one's actually registered specifically for that purpose since April of this year. So yes, no, they've been available for some time. Cost is an issue. Really, it is an issue. But patients on middle to high plans, they do tend to cover 80 to 90% of the costs are covered by the medical aids if they do approve it. There's always going to be a small co-payment for these conditions. That's unfortunately inevitable. I know for Ipf, there is a program available that if the medical funder initially declines, there is an NGO that can help us get at least 50% of that cost covered. So that is also available to treating pulmonologists, that if you get the initial decline letter, you can get nintedanib through this program, and I really don't mind if those doctors contact me, I can help them set that up. And certainly the pharmaceutical company running this, they are trying their best to push this, to make it available. There really shouldn't be any excuses not to have these drugs available. And they do work. You know, if you look at trial data, they would not have been registered if they didn't work. A third of the patients really do extremely well. Another third will do well and they won't progress. And yes, unfortunately, there's a smaller group of patients that just relentlessly decline. But I would say 60 to 70% of patients on these drugs absolutely show benefit. Side effects limited mainly to diarrhea and skin rash. And then about 5% of cases, 1 out of 20 patients, the side effects are severe enough for you to discontinue the drug. But then after a month or two, we then retry it at a lower dose. So we try our best to keep these patients on those drugs, you know, because they are effective.
Oh, that really is encouraging. And sure, I think maybe that Rare Diseases South Africa can maybe help facilitate with this information. And we can pull something together that we can send out to our various networks and patient groups that are, you know, included on our database for this condition. And maybe we can facilitate that, but I'm sure NOMSA will be on that and send out a communication. And if need be, we can almost maybe set up a little standard operating procedure just to go through a process so that when necessary, those physicians can actually connect with you.
I do think, yeah, the medical director of one of the companies that I work with, I think to close that gap between you and them would be a great contact to have.
Okay.
You know, and to open up the availability to the public so they know about it. They cannot advertise to the public directly, but certainly via the Rare Diseases Foundation, they can certainly do that. Yeah,
that's what we do, and we fill that gap a lot. And I know that Kelly can't speak, but she's writing this down because she's going to be getting onto that tomorrow, no doubt. Just to wrap up your session with a couple more questions. There's an anonymous question saying they're newly diagnosed. Are there any lifestyle changes that they could make just to, you know, improve their symptoms?
Okay, so lifestyle changes. The first one, there's some data for this, not a lot, but that you can potentially symptomatically help yourself by reducing acidity and reflux. There is the small association between reflux and lung fibrosis. So that would be one thing, you know, a good diet, reducing acidity, you know, reflux, heartburn, treating all of those, and then also to keep fit. And with keep fit, that's a very easy thing to say, but it needs to be a medically aligned rehabilitation program. So we do see patients that if they sort of stop, they stagnate, they sit all day, they do much worse. So if you can get hold of a biokineticist or a physiotherapist that do perform pulmonary rehabilitation, and there are not a lot of them available, but if you go for pulmonary rehabilitation early on, it makes a massive difference. Because the moment you start losing body weight, losing muscle power, you know, especially if you have concurrent osteoporosis, you know, you will always decline much quicker. So I think staying fit, having a medically aligned rehabilitation program in place, looking at what you eat, certainly if you are obese, we don't see many obese patients with IPF, but certainly if you are obese, try and treat those risk factors. If you're hypertensive, diabetic, treat those risk factors. Because at the end of the day, many patients with IPF die from related cardiac disease, not just the lung problem, but also from cardiac disease. So general cardiac health, blood pressure, diabetes, weight, and then of course the diet, you know, looking at foods that will promote less reflux, less heartburn, and then the rehabilitation and exercise. So that will be a good start. We do always, you know, I do always point out that I think the psychological aspect needs treatment as well. The diagnosis of IPF for a patient, once they truly understand the disease, is extremely similar to being diagnosed with cancer. As I've said, in certain cases, if it's diagnosed late, the prognosis is even worse. So I think psychosocial support, treating depression, treating underlying anxiety, because it's impossible for a human being to look at this diagnosis and not be confronted with death, not being confronted with all these questions. And doctors don't always have all the answers, or they might be apprehensive to give you the answers. doctors aren't always, they can't always relay death really well. We don't talk about it enough. So we sort of just say, well, there's your diagnosis, there you go. Many patients go home without all the answers. They don't know what's lying ahead for them. And they need that psychosocial support. So where necessary, do get a counseling or a clinical psychologist on board, because patients that feel better and do better in terms of rehabilitation do have better outcome as well. So those are the starting points. And then certainly the next step is going to be to get you on antifibrotics as soon as possible. Yeah.
Okay, thank you. And I guess, your recommendation, to get the psychosocial support also applies to the family members as well, because it's a diagnosis that affects everybody, not just the patient. So that would be really important. And just one final question for you. It's from Michelle or Michele, I'm not sure. Obviously a strong family history of IPF, losing the father at age 56 and the brother has passed on at age 52. And now Michelle has been diagnosed at age 56. She's considered early in terms of the status of the disease and very, very happy to participate in any studies ongoing. They have both, and she says ironically that both her father and her brother were treated with steroids. So which you contraindicated earlier. So are there any studies that they could participate in, or
Yes, there are. So I'm currently busy with a company called Synexus. They have 2 trials that is currently in the phase of evaluating certain premises to see whether they are adequate. If they do find those sites, pulmonology practices adequate, we will have those available. So patients who end up not being able to afford treatment, who is not on a medical aid, for example, or where funding has been consistently declined, yes, participation in a study is certainly going to be possible. And I think, I'm trying to think what's going to make this much easier. I wonder if it's going to be practical if that study becomes available, and it should be within the next 2 months. They want to start with this before the end of the year. That I can forward that information to you, and you can maybe put up an email address and say, well, if there are people that want to participate, where do you stay? Where's your area? Because there will be, probably the main city centers, Joburg, Pretoria, Cape Town, Durban. We should be able to liaise with doctors in those areas. But I know about 2 trials. 2 trials that are about to start.
Yeah, please do send any information. We often circulate that information for relevant patients and members of rare diseases. So please do, and we'll connect you. So Michelle, I hope that helps connect you in that respect. So I just want to move on to the next section of the webinar, because we've run over a little bit because it's just so interesting. And Nomsa is saying, thank you very much, Doctor. You've opened her eyes. So I've certainly learned so much already. What's interesting is a lot of the things that you're saying are commonalities with a lot of other conditions, but what's different here is that something can be done. And I think that really motivates us to move on more quickly and really put the pressure on and keep the pressure on. So I'm just going to move over now to Stephanie. Stephanie, I've got a terrible Afrikaans accent. Stephanie Groenewald, I apologize. Groenewald, yes. And Stephanie is a biokineticist, and she has worked with a lot of patients on the biokineticist side of things. So almost the next stage after Dr. Viviers is diagnosed and is got the overseeing, management of the condition, this is where Stephanie comes in, and with her experience, she can really help patients who are dealing with physical activities and obviously breathing issues, I guess, just to help them to have the best possible quality of life. So Stephanie is just now going to tell us a little bit about, therapy and possible breathing exercises and physical activities that can be done just to help with your everyday life, I guess, Stephanie.
Yes, thank you so much, Helen. Yeah, so Dr. Viviers touched on so many subjects and so many points that I would like to raise when you are treating or rehabilitating a patient with any lung disease, really, or any disease. First being, are we dealing with only IPF, or are we dealing with other diseases as well? So I do have a background in psychology as well, which I think is important to mention, because as you also said, working with these patients, to a lot of them, it feels like a death sentence. And we have to understand that they need a lot of empathy. They are going to become almost one of your family members. They're going to be with you chronically. And you're going to have to realize to work with them slowly and understand what they're dealing with. The breathing exercises that I will touch on shortly really helps with this, as well as stretching, I find. These patients are often older, as he has mentioned. Although lately in the COVID patients, I've come across many young patients with lung diseases and scarring, which makes it quite scary, to be honest, to deal with these patients. But I will tell you exactly how we see it in practice. So when empathy, when we look at breathing exercises, as I said, it helps for stress as well, quite a bit. So that's your normal breathing exercises that I'm sure that a lot of the doctors also tell their patients about, where you lie on your back, arms open, shoulders relaxed, and you breathe in for 2 to 3 seconds through your nose and out through pursed lips. In other words, out through resistance. Some patients I also advise, especially if they're quite playful, to breathe in through or breathe out through a straw into water to create resistance for 2 to 3, 4, 5 seconds. See if you can breathe in, hold it for a few seconds, and breathe in even more, hold it for a few seconds. How I often describe that to patients is breathe in a square. And to come back to the stress level is, I've seen patients burst into tears because for the first time in a long time, they're actually breathing. So what I mean by breathe in a square is, if you look at a little square and it takes you 2 seconds to breathe in, you're not allowed to breathe out. You breathe in again, and you breathe in again, and you breathe in again, and then you breathe out. And that actually betters your lung capacity, depending on, of course, how severe your IPF is or whatever lung disease you have. And then, of course, you need to do this in reverse as well. So you breathe in through pursed lips 2 to 3 seconds and breathe out through your nose. So I usually say to people, do the squared breathing outwards 5 times, in 5 times, and do the pursed lip breathing in and out through your nose 5 times each, just as a start. Sorry. Yeah, another nice thing for them to do is blowing up balloons. I don't know when last you tried to blow up a balloon, but it's not as easy as it seems anymore. So I often ask them to just blow up balloons all the time. Okay. Now, the best physical activity for a patient with lung disease is, of course, cardiovascular. Now, it's not only stress levels, it's obviously also endorphins, and that betters with their depression, or helps their depression quite a bit. So we have to remember that we need to exercise at 60 to 70% of your maximum heart rate, which there's this little formula, which I'm sure most of you know, where it's 220 minus your age times 60 to 70%, which gives you the optimal heart rate to train at. The reason for this is, otherwise you are not using oxygenated energy, aerobic energy, you're using anaerobic energy and protein molecules like a sprinter. So you need to actually train at the correct heart rate. What I find an easy way to make sure that the patient remains at the correct heart rate is to do interval training. Now, as the doctor said, these patients are often sedentary for a long time. They don't feel like this. Life is not great at the moment, and you need to really, really, really stand by them and support them. So if you can say to them, okay, let's just do 3 minutes. And it's very important to understand that working with patients like these, especially from the cardio aspect, can be dangerous. You need to monitor their blood pressure before, you need to monitor their blood pressure during, and you need to monitor their blood pressure after to see what the strain on the heart is. And for any professional in my industry, you'd know that where your contraindications of exercise comes in. What happens to your blood pressure, when to stop, when to slow down. Okay. But so let's say we're working with a patient whose heart rate needs to stay at 120. So if you see at minute 2.5, it increases too fast, it's easy to slow them down. It's also more motivating for them to know it's 3 minutes. Now, remember, we need to go to about 30 minutes of cardiovascular exercise to actually get the physical benefit of it. So it feels very long, but it really isn't. We ask them about their animals and about their children and about everything else. And before they know, the 30 minutes would be over. a controlled environment. So I said here in my notes for tonight, it usually depends on the patient, but it is my preference to do it on a recumbent exercise bike rather than try and go and walk outside, because you need to have access to your doctors, especially with patients that might be in a higher stage, or that might have any other contraindications. Interval training. So, COVID. I've had marathon runners of late, of 30, 40 years old, who were at me the 2 weeks before they went into isolation and running like lunatics. And then they came back, and then they did a plank, and their heart rate went up to 150. And that, as I said, that's pretty scary. So what I have found, that the same sort of program, doing interval training, very controlled, and you need to teach your patients how to do it themselves, how to control themselves. I mean, 90% of people now have access to fitness watches, and they are quite accurate, to say, when your heart rate gets to X, you need to stop. When your heart rate gets to Y, you need to slow down. So I like my patients to understand what we're doing, because the results are way better. And they also feel empowered by it. They feel like they're taking control back, because they've been diagnosed with this terrible thing and they have no control. So for them to give them control back is a huge thing. What I have seen in COVID, so as Dr. V said, IPF is a very rare disease. But what I've seen a lot with COVID is something that I've started calling is an exercise deficit or oxygen deficit. What I mean by that is, it's very normal when you exercise, your heart rate goes up. What happens in these patients is their heart rate goes up to a certain point and then drops dramatically. Although the exercise is being increased, or you're going for longer, your heart rate drops. And as soon as the patient stops, their heart rate shoots up. So that's why I'm saying a deficit gets created. So I have shown my patients that if your heart rate stays the same, then you can continue on, let's say until your 3-minute interval's reached. Then let your heart rate come back to about 20, 30 beats above resting. And then we can increase again to the maximum of 60 to 70%. If you see that sudden drop in heart rate, you need to stop and sit. And breathe deeply until your heart rate comes back to, again, 20 to 30 beats above resting. Because this is the scary thing. I mean, I have graphs and people sending me data on Strava, especially the runners, because not all of them were believers that this is actually dangerous, of how they were running, and then literally it just drops and then shoots up. So it is real. It's really, really real. And people need to understand that that is actually a way of damaging your heart. So yeah, that's something that I can't emphasize enough. Yeah, what would you like to know?
So, wow, Steph, that was incredible. I mean, it's such specialized knowledge. And I'm thinking, do all the biokineticists out there have the same level of information or access to this information? Because I'm thinking, people listening on Facebook, they think, well, I can actually do exercise. Somebody has said that they've been diagnosed and the doctor said there's nothing that he can be done for them, and in limbo in terms, I guess, of both treatment, but also exercise. So is there information on this on your website, or where can, the general person on the street get this kind of information? Because they don't want to go to a biokineticist who's clueless about this, because there's biokineticists and there's biokineticists. So
yeah, I hear you. The thing is, to be honest with you, so I've worked in rheumatology for a long time, which is it's a disease that is very unknown. And because I've really concentrated on chronic patients, when COVID happened especially, I went out of my way to figure out how to help these patients, because it's just an impossible thing for me to think that someone can't exercise. Psychologically, physically, unless you are at a space in your life where you're going to stay on the couch, you need to exercise, because your body needs to be conditioned. And I've always said to people, please understand, your body goes into spasm or you feel short of breath because you're putting a load on your body that it is not trained for. If you have back pain, your abs aren't strong enough. Exact same thing. So I would be very happy to give you the information and you can distribute it. As for exactly where they can find someone that has gone deeper into finding out exactly how to help these patients, I don't know, to be honest. I'm in Johannesburg, as I think everybody is, but I have 1 or 2 colleagues, one in Pretoria, one in Cape Town, that I know if someone asks me, I refer to them. But I'd be very happy to just give you an outline, as I would do with a patient that sees me.
No, that would be great. And we have toolbox information on our website that we can bundle a lot of this stuff and put it in there and make it available to our members. So definitely, that would be great. Thank you.
I think it's also important to ask your biokineticist, because people specialize in different things. And it's just important to know, has this biokineticist worked with these people before? Or are they more inclined to work with sports people? It's just important to ask, I think.
Yeah, and I think it comes back to the responsibility of the patient as well. So back to what Dr. Viviers was saying about exercise and, eating right and avoiding acidic foods and so on. It's the onus is on the patient in that regard. I mean, you can take a horse to water, but you can't make it drink. You can say, but the patient does have to take that on, which I guess is a bit harder when you've got all the psychological issues and dealing with the diagnosis and all those kind of issues as well. But so and that's what we're here for as well, just to help keep patients informed and provide guidance where we can. There's another question come through from Facebook, Stephanie. So she says, thank you for this. I have not been diagnosed, as I went from a misdiagnosis of cystic fibrosis to asthma, from pneumonia to pulmonary hypertension. And they're saying now that they're feeling educated and have a direction. So I guess that means maybe they're going to go to a specialist or a pulmonologist to see if this is, and have that CT scan if possible, to see if that is a diagnosis. So, Yeah.
Look, I've always said biokinetics is probably the easiest profession in the world, because anybody who moves feels better. And what I would like to say to the patients is, please, within reason, don't try and train for the comrades tomorrow, but you will feel better. You will feel better if you become physically active. You will feel more empowered. If you get in contact with someone or the information I give you, you'll feel better. I promise you. I've not had someone who does not, feel better once they become physically active. And that's why I say it's a very easy profession, because people feel better when they're active. It kind of speaks for itself, psychologically, physically. It's the cheapest form of medication there is.
Sure. And there's another question, and it's the question that I had in my mind, but you said it very quickly. Could you just say that formula again, for the 60 to 70% above your maximum or your heart rate?
So it's 220 minus your age.
Yeah.
Times 60%.
Okay.
Yeah, or 70%. And as I said, that puts you in the range of aerobic, energy systems. Anything above that, more than 70, 75, 80, you start building muscle. And which is necessary for people with osteoporosis and so on and so forth. But we are talking about lung disease, so yeah.
And would maybe a final question before we kind of do a sum up, let's say a patient comes to you with IPF, would they need a letter from the doctor, from Dr. Viviers or a pulmonologist, saying this is the diagnosis, this is the stage or whatever, before they can start exercising? How would that work? Because we don't want to keep going on and exercising.
It is preferable, and there has been instances where a patient comes and I then say, I think you need to go to a pulmonologist, or I think you need to go to a rheumatologist. The thing is also, they need to get onto their meds. They need to get onto the correct medication. And I cannot do my job properly if I don't have a good relationship with the doctor. I need to know what this patient is all about. I need to know if they're on a beta blocker, because your heart rate response will be different. So it's very important. So often, even if the patient hasn't been feeling well and they end up at biokineticist because they aren't said yet they should go, it does just end up going, please go to a pulmonologist. I think you need to investigate this further, and then I will get into contact with the doctor anyway. So it's full circle. Yeah,
it makes sense. Thank you.
Pleasure.
So I see we've got about 5 minutes left. So Stephanie, if I could ask you just to wrap up and just have your closing comments, please.
I think I said them. I'm kind of like begging everybody to become physically active. But no, really, if there are people that need advice or that need help, I think any profession in the medical industry is all about giving back. And I'm sure you'll email me tomorrow, and I will send you whatever's needed from my point of view. Please just keep in mind that should you have any other pathologies, you need to be assessed properly. So although I will give you the outlining information like the formula, if you are on specific medications, if you are, as I said, on beta blockers, please be assessed properly, because sometimes we do like training at different heart rates, or just, I think just be assessed once at least by a professional. Okay, so proper assessment and exercise can really help. I mean, both psychologically and physically. So that is something that you can do to improve the quality of life. Okay. Absolutely. Thank you so much, Stephanie. Pleasure. That was really enlightening and inspiring. I'm going to get on my exercise bike tomorrow. I hope so. And I'm just going to hand over now to Dr. Viviers. Just if you could give us your final comments, please.
Thank you so much. And I appreciate that talk, Stephanie. And it's always good to have people that are passionate about what they do. And I cannot agree more. Not all physiotherapists and biokineticists are trained. Some like doing, knee replacements. Some do, hips and backs. And some people have a passion for lung disease. So do find someone like Stephanie to walk the path with, because that is worth its weight in gold. And I think the message down for tonight is that this isn't a death sentence. It used to be. I think 10, 15 years ago, we didn't have much else to do. We gave you an antacid and oxygen and you went on your merry way. But I think we've come a long way. We are certainly learning more and more. The data that we get, I mean, the IPF guidelines used to come out every 10 years. Now we have, in the last 5 years, we had 3 revisions of the guidelines. So the American Thoracic Society, ATS, and Respiratory Society, ERS from Europe, have now also recently launched the 2022 guidelines again. So every year there's more data coming out, diagnosing earlier, helping us to treat properly. And we certainly have more to offer patients, and it doesn't need to be a death sentence anymore. There's help available. I think that's the most important take-home message for this condition.
Wow, thank you. I mean, it's really encouraging. I mean, you've made it clear that it is a serious diagnosis, but I think you've tempered that so well with, there are things that can be done, especially with early diagnosis, and putting pressure on, motivating for access to treatment, and then in parallel to that, we need to advocate and educate, and we need to everyone needs to get on the train, and we need to get that train going.
Absolutely.
So, to really make a difference in the lives, the quality of life of those affected and their families. So thank you very much to both of you for joining us tonight. I don't see any more questions or comments that have come through, but I know that Kelly would want to say, and both Nomza and Kelly would want to say thank you so much. This is going to be available, this recording, for other patients who are going to glean so much. And we will follow up with all the requests for information and so on, so we can sort that out and bundle it and pitch it appropriately and make it available to our members. So thank you so much for that. That's another step forward that we're taking into helping improve the quality of life of those affected. Thank you so much.
Thank you.
Have a great rest of the night, everybody. Thank you.
And you. Bye.
Okay, bye.
Bye.